In 2006, I fulfilled a lifelong dream that I had of being a full-time volunteer in the mountains of Honduras as a family doctor, working for the organization Shoulder to Shoulder. I went with the intention of serving the poor and needy, and I left with a career-changing experience and many lessons. One of the biggest lessons I learned, surprisingly, was how I could take good care of my patients here in this country. So today I wanted to share with you some of my experiences of working in a small clinic in Honduras and the lessons I learned there about how we take care of the poor in clinics in this country. There's a concept that's been described by researchers at Dartmouth that's called reverse innovation. And the usual paradigm is that innovation occurs in the rich or so-called developed countries and trickles down to the developing or the poor countries. But reverse innovation teaches us that innovation can come from the global south. And it's my belief that we have much to learn here in the global north from our partners and colleagues in the global south. So today I want to share with you some examples of reverse innovation. But in order to do that, I need to share with you a little bit about my experience so far. So I was a country doctor in Wisconsin, and in 2006, my family, which included 3 children, ages 6, 5, and 1, we decided to move to Honduras. For 2 years, we lived, we worked, we slept, we ate, we played in our clinic. My children went to the Honduran public schools. We went to weddings, we went to birthday parties, and we were so fortunate because we became part of that community. Since moving back to the U.S. in 2008, I have been working at different inner-city health centers with the poor here in Cincinnati. Every day, I am struck by the similarities between my patients in Honduras and my patients here in Cincinnati. Every day, my patients ask themselves the same questions. How am I going to put food on the table for my kids? How am I going to get to the clinic? How am I going to buy my medicine? This reminds me of one of my first patients whose name was Fatima. Fatima was a beautiful 26-year-old woman who was born with a congenital problem called spina bifida. Now, if you're born with this type of problem in Honduras, there's no orthopedic specialist in the mountains. There's no physical therapist. And so Fatima had 2 deformed feet, and she really just couldn't walk very well. And so even though she was very intelligent, she couldn't navigate the muddy, mountainous path to the village, and so she never went to school. As I took care of her, I started doing more reading about her problem. Spina bifida, which is considered a neural tube defect, is a congenital defect that is thought to be very common in this area of Central America and thought to be due to a lack of folic acid in the diet. Now, folic acid, as you might know, is a B vitamin. It's found in green leafy vegetables, and the developing fetus needs folic acid for healthy development of the brain and spinal cord. Shoulder to Shoulder was the organization that I worked with in Honduras, and it was founded on the principles of the determinants of health. The idea is that health is affected by much more than just our medical care, but by the conditions in which we live, work, and play. The food we eat, the water we drink, our house that we live in, our ability to find work with a living wage, our quality education, all these things affect our health. And that makes intuitive sense to us, right? So shortly after I met Fatima, our organization was very fortunate to receive a shipment from the Ministry of Health of Honduras of 5 million tablets of folic acid. Well, you can imagine my excitement. I was thrilled. I was so excited to be able to prevent problems like Fatima's in the communities. But as I started thinking, I was worrying. I thought, well, how am I going to get all these tablets out into the communities to the women who really need them? And how will we teach the women that they need to take these tablets every single day before they even know they're pregnant? And how will I make sure that they're even taking this medicine? So after much discussion and thought, we did the only thing that we could, and we took our dilemma out to the communities. And we started in the communities that had the highest rates of birth defects. So we actually started in Fatima's hometown of San Jose. We went to San Jose and we asked for volunteers who were interested in preventing birth defects in their community. And before we knew it, we had this incredibly dedicated group of men and women who were interested in improving the health of their community. They underwent a brief, intense training in community health, and soon they were out in their communities, visiting their neighbors and delivering folic acid tablets. But they did a lot more than deliver vitamins. They delivered support and education and encouragement. And in fact, they even came up with some new ideas for how to improve the health of their community. They started their own home garden demonstration project to teach their neighbors how to grow healthy fruits and vegetables. They called themselves the Madre Guias, or Mother Guide in Spanish, and they're part of this global workforce that we call the Community Health Worker movement. Community health workers are a perfect example of reverse innovation. They transcend the social determinants of health that we talk about because they meet patients where they're at. They live in the same communities, they speak the same language, they wear the same dress, they understand the problems that their patients face, and they help patients and communities problem solve. They address these social determinants of health. Every day in my clinic in Honduras, I was able to address those social determinants of health. If a patient came to me and the child was malnourished, I was able to connect them with food, nutritional support. If a family came and they didn't have access to clean water, I was able to give them a water filter. And for some families who were struggling with unsafe living conditions, I was able to help them out with safe living conditions. Which brings me to another story of another patient named Maria. One Saturday morning, I was seeing patients in my clinic, and Maria brought her 4 children to see me. One look at the family, and I knew they were struggling. The 2 younger children, a toddler and a young girl, looked malnourished just by looking at them. And the 2 school-aged boys, I later learned, were struggling with a heart problem that we rarely see in the United States called rheumatic heart disease. We don't usually see this because it's caused by untreated strep throat. As I worked with Maria over the coming weeks, we were able to connect Maria with some nutritional support, and we were able to connect her sons with heart specialists and testing for their heart. But I could see in the months that came ahead, they were still just struggling, and unfortunately, one of her sons died. So I decided to go visit them in their house. And as I walked to her house, I could see her house was just barely standing. It was raining, and there was water coming in through the roof in multiple areas. There was no running water. There were dirt floors. There was no electricity. There were 4 children, but no books, no toys to play with. I was warmly greeted by Maria's husband, who was also blind, and by Maria, and they happily shared their news that they were expecting triplets. And I looked around this house and I thought, how can anyone be healthy in this home, let alone newborn triplets? So fortunately, our organization, along with help from members of my church here in Cincinnati, were able to build a home for Maria and her family. And the triplets are now 3 years old and doing well. So thinking about Julia's or Maria's home, we can understand how the life expectancy in countries like Honduras are shorter than in the U.S. But what you might not know is that in the U.S. currently, according to a study by the National Academy of Sciences, the poor die on average 12 years earlier than the rich. 12 years. So what do we do about that? Well, I think in order to address this inequity, we must draw on lessons from the Global South in this spirit of reverse innovation. We must learn to address the social determinants of health in our healthcare system. Here in Cincinnati and here in the U.S., we're just starting to learn how to do this. At Crossroad Health Center, where I work, we're doing this in a couple ways. First of all, we have an army of undergraduate volunteers, some of whom are here today, who reach out to our patients and help them navigate the highly complex U.S. healthcare system and help them break down those barriers to specialty care. Secondly, we have our own community health workers here, and they visit our patients with diabetes and our patients with, who are pregnant and help them achieve their health care goals. Finally, we are starting to pilot programs where we screen all of our patients for their social needs and connect them with community agencies who can address those needs. Over the last decade, I have been very fortunate to work in 6 different countries throughout the Americas. And the lesson that I have learned is this: the poor struggle with these social determinants everywhere. They're very similar. The struggles are everywhere. The food we eat, the water we drink, and the conditions that we live in. These are the social determinants of health, and this is where health starts. And that's where our healthcare system has to be. But in the past, our U.S. healthcare system has fallen short for the poor and the most vulnerable people in our society. But I hope and I believe that we're entering into a new era of reverse innovation, where we can look to our partners in the Global South and learn new ways of addressing health and integrating the social determinants of health into our healthcare system. It's an exciting time for us as physicians because we can work in teams with care coordinators and community health workers and other professionals to support our patients, not just medically, but socially as well. As healthcare providers, if we want to improve the health of poor patients in our clinics, we have to ask them about their social problems and not just their medical problems. I believe that we as physicians cannot close this 12-year health gap alone. But fortunately, we are not alone. We can learn from our partners abroad, and we can learn to look at those root causes of disease and illness and start addressing both our patients' medical needs and our social needs as well.